Welcome and good afternoon. This is Kelly Pfeiffer. I'm with the California Healthcare Foundation, and we're delighted to have you join us for this webinar on making life-saving naloxone accessible. We have 3 experts who are joining us today, so we have an action-packed agenda. We'll have a little time for questions at the end, but we realize there may be questions we can't answer, and so if you have them that don't get answered, feel free to email us and we'll make sure that your questions get answered, because we have so many opioid safety coalitions actively working to get naloxone into the community, and we want to make sure you have all the resources you need. Next slide. Our presenters today, first we have Dr. James Gasper with the Department of Healthcare Services, who's going to be going over some of the regulatory frameworks and some practical tips about how to get naloxone. We have Dr. Gary Tsai with the Public Health Department in Los Angeles, who's one of the leaders of the coalition in Los Angeles, and he'll be walking us through how they're doing it in a massive county like LA. And finally, Dr. Philip Coffin is going to be sharing the results of the study that are very encouraging to why we should be making sure naloxone is available in our community. Next slide. So just a little bit of housekeeping. Because we have over 200 people registered, we're going to have everyone muted during that presentation, but we do have the option to do chat questions. So if you have logistical challenges, feel free to use chat for the host. And there's a question box to the right, and please use that if you have any questions. And again, we'll do our best to answer them during this session, and if not, we'll try and answer those offline, or of course, if you can always email us directly at the foundation or email any of the speakers, and they're happy to answer your questions. Please do stay online to complete the survey at the end, as we take your feedback seriously, and we'd love to hear from you what other topics would be helpful for you as you do this work in your community. This session will also be recorded, so if you or others want to listen to it, it'll be available on our website along with all of the slide decks from the presenters. So now I'm going to hand it over to Dr. James Gasper. We'll just have a minute to get that slide deck up and running.
There we go. Thanks, Kelly. So thanks for having me here to talk about this. It's kind of a few areas that we've been spending a lot of attention on, safe prescribing and access to MAT being the other two, but I think naloxone needs a little bit of help because we've been faced with a number of challenges in getting it distributed in our communities. And today I hope to give you some more tips and background information and really some practical advice on how we can get this drug moving and out in the community where it can save lives. So there's a few main areas I want to cover. One is the relevant laws. There's always a question that comes up is, what's the authority to provide naloxone? The second is the formulations, and we've had a few new ones added. So I'm going to talk about those. And then third, I'll specifically go over the quick and dirty way of getting naloxone out through co-prescribing, community distribution sites, and through pharmacies. All right, so here's the statutes, and you can see this has all happened pretty recently, starting in 2012, and this is the year that the governor signed the legislation, so these are implemented usually the January after. The first one was the Good Samaritan law, which protects people at the scene of an overdose who call for help, and we know that it's important to call for an ambulance, but when you're committing a crime at the time, people are often scared to do it. So this was the first step in the right direction in order to protect those there who may have drug paraphernalia on their person. As long as they're not committing another crime, they won't be arrested for asking for help. The second, which was a huge step forward, was the California Overdose Treatment Act, signed in 2013, and this provided both protection for prescribers and for bystanders administering naloxone, liability protection for them. It also legitimized the standing order process, and the standing order is when a physician signs over the authority for naloxone to be distributed by medical or non-medical personnel at community distribution sites. It also permitted third-party prescribing, and this is pretty unusual. There's not many drugs that we're allowed to prescribe to a third party, and what that means is if Mrs. Jones comes in because her husband uses heroin, she's able to pick up the naloxone and she can use it on him, and she can actually be the one that receives the prescription. There's very few examples of this that exist, but we do have the authority through this act in California. And the last piece of legislation was the pharmacist furnishing, signed in 2014. We had regs that next January in 2015. And this allows pharmacists to furnish naloxone under a statewide protocol that was developed by the medical board and the Board of Pharmacy. And the only requirements are an hour of CE, and then there's some screening questions the pharmacists have to do, and they have to consult the patients. But we'll get into that in a little bit more detail. These are the laws that we have, and we'll kind of talk about how they apply. So what about the formulations? Well, naloxone's been around for a long time. Since 1971, we've had this drug. And here we are 45 years later, we're finally starting to talk about it being available in the community. The earlier form is probably the intramuscular, and that's the one that we first used in the community. And this dates back to the mid-90s when it was first being distributed to injection drug users. About 10 years later, we were able to get the intranasal product out. And at first it was this pre-filled syringe that you see on the right-hand side of your screen. But you'll notice a little white tip there, the atomizer, and that's been our Achilles heel. It's difficult to get, it's impossible to reimburse for. And the kit itself is kind of clunky. It's not the best easy to use device that we could have created, but it avoided needle sticks, and people were a lot more comfortable using the nasal spray than they were the injectable. So those have both, been in use for quite a while, and we became comfortable with them, including the challenges. In the last few years, we've had a few new products come out, gotten lots of attention. The auto-injector was approved in 2014. It's a beautiful little device. It talks to you, and it's very easy to use. It's still an injection, but it pretty much does it itself. You just have to line it up on someone's thigh, and it does the rest for you. A year later, we had the commercial nasal spray, and this is something we've been waiting for a very long time. It takes the convenience of the nasal spray and removes all the hassle of assembling the kit and getting the atomizers that really created a lot of problems along the way. But I want to talk about some of the challenges and the differences between these different formulations. The first thing that I'll point out is the cost, and this is probably no surprise to anybody, but the price of naloxone has gone up substantially. We were paying $2 or $3 a vial for the 0.4 milligram 10 years ago, and now we're looking at about $15 a vial. So this is the approximate retail cost. It varies a lot depending on where you buy it from, your contracts, etc. But these are the approximates. So 2 of the vials is about $30, double it for the pre-filled syringes. The AWP of the nasal spray is around $150, and that's right, the auto-injector is now $4,500. It started off, I think, about $650, so the price of that has gone up, tenfold in just a few years. As far as the coverage on the Medi-Cal contract drug list, all of these products except for the auto-injector are on the contract drug list. They don't require a TAR, but they do have to be submitted directly to the state. These are carve-out medications. So if these are submitted to the managed care Medi-Cal plan, it'll reject. It'll say bill fee for service or PA required. You have to tell the pharmacies to submit it directly to the state. Just a brief summary of the different products. The IM vial, it's really beautiful in a lot of ways. We can get both the syringes and the drug in community pharmacies. They got sharps containers. It's cheap. We can pay for all the components of it. There's really a lot of good there. The problem is that not everyone's comfortable with needles, particularly our pain patients. So that was one of the major barriers. The intranasal prefilled syringe avoids the needle stick injury. It's not as easy to assemble. It was difficult to prescribe, and we tried implementing this into our primary care sites, there were a lot of problems with prescribing this product and getting the right one actually to show up at the pharmacy, because there's a lot of other pre-filled syringes that look very similar to it. Then again, the atomizers, they're just not available in our traditional pharmacy supply chain, so they're very challenging, and we couldn't pay for them because they don't have an NDC number. The auto-injector, easy to use but costs a fortune, and the commercial nasal spray, also easy to use, much more affordable. One thing I didn't point out is the dosing on it. It's double what we were using with the pre-filled syringe. And there's been some concern over precipitated withdrawal. The other side, with the community exposure to fentanyl and carfentanil, the higher dose may be necessary, so there actually could be some use for it there. But in other cases, it may precipitate withdrawal. All right, so what are the venues that we can get naloxone out? There's really three big ones that I want to focus on today. This isn't an exhaustive list, but these are the three that I want to talk about. The first one is through co-prescription, and that's in reference to co-prescribing with opioid analgesics. The second is through community distribution sites, and these could be needle exchanges, they could be community centers, it could be primary care clinics. And the third is pharmacies, or pharmacist furnishing. Like I said, this isn't an exhaustive list. There are many other places that we could and should have naloxone available. Clearly, first responders, including law enforcement, paramedics, at discharge from jail and emergency departments. There's many other places, but I just want to focus on these three, and these are probably the areas that the coalitions are putting much of their efforts into. All right, so what about co-prescribing? As I said, it's prescribing naloxone along with an opioid to a patient that's presenting in the medical care system. The good thing is that it's a prescription. It can be covered, reimbursed by the third-party payer, and dispensed from the pharmacy at the same point in time as the opioid itself. I would say that pretty much everyone that's exposed to opioids fits into the category of being at risk, but that's a little bit too nebulous. So one of the ways to approach this is to come up with some very black and white criteria that you can share with your primary care providers. And this is just an example list. It's not exhaustive, but you're going to have to pick something. You know, if you're going to go into a clinic and say, we want you to prescribe naloxone, the question is, well, who do we prescribe it to? You have to give them some examples. And you can pick some low-hanging fruit, the riskiest combinations of medications. You can pick a morphine equivalent dose of whatever. It seems to be changing on a daily basis of what we think safe is. Or alternatively, you can go with the quantity of pills. You could say anybody that's getting more than 6 pills a day, forget about what the morphine equivalent is. It could be 6 pills of oxycodone or 6 Norco. Whatever the case may be, that may be more convenient, but you can just pick a cutoff that everybody can use to co-prescribe naloxone. You can also look at high-risk combinations like opioids and benzos. We know that that combination in particular is involved in a large percentage of our overdose deaths. And you can also look at high-risk patients, those that have had a history of an overdose, particularly if they had an overdose, went to the ED and came in to see you, might want to also look at their opioids being prescribed, and anyone who's using opioids intravenously. So in addition to having kind of the simple list of criteria, I would also think about automating this whenever you can. More sophisticated electronic health records can bring up notifications when you write prescriptions that meet any one of these criteria, and it can notify you. You can even go for kind of an opt-out process where everybody that gets an opioid prescription gets naloxone unless you decide not to give it to them. Automating it's going to make it a lot easier. So consider that in the technology capabilities that you have. All right. So the next venue that I want to discuss is community distribution. And like I said, this is really the quick and dirty way on how to get a naloxone distribution site set up in your community. The first thing that you have to do is pick a location. And it could be, something logical like a needle exchange site, or a place in the community where people congregate, which could be a library, community center, primary care clinic, homeless shelter. These are all possible. It depends on who is willing to work with you, who has space. But until you have a location to distribute the naloxone, it's going to be very difficult to do anything else. You also need staff on site, people that you can train to distribute it, and some secure place for storing the drug. After you got a location, you have to get a signed standing order. We talked about this earlier. People that you can hit up are any sympathetic physician in your community, your health officer. Physicians that are trained in addiction tend to be very supportive of this. Or if you can't find somebody, go next door. Find out if another community close by has a physician that signed off on a standing order that they will extend to you. It's really a good chance to partner up. After you get the standing order, you have to train at least one person on site to do the patient training and education. And there's training materials available from the Harm Reduction Coalition on how to provide this, and I'll get to the link in a second. So after you've done the training, you get a standing order, no location, you're going to have to collect some supplies. And in order to collect supplies, you guess that you're going to have to come up with money. And, a lot of programs like this really start with kind of the pilot idea, and that seems to be more agreeable when it comes to asking for money. We just want to start this. We want to test it out and see how it's going to work. So you don't have to guarantee ongoing funding at first. That may be too much of an ask, but at least see if you can get something to get the process started. Enough to buy some naloxone and to rent the space if you have to. When it comes to choosing the naloxone product, remember that the vial is the cheapest, but the commercial intranasal is probably the most convenient. And depending on your community, you may want to consider one or the other or both. When it comes to documentation, you'll have to record people that are receiving it, particularly when they come back for refills. What happened? Did it expire? Did they lose it? Did they use it on somebody? And what were the circumstances? That's data that's very useful in sustaining these programs. And you also want to have some information for the patients, and even a pocket card that says, basically, I got this under a standing order. Sometimes naloxone's been confiscated by police, so we want to discourage that from happening, and this pocket card can be helpful. And then some way of maintaining your drug inventory. Here's the link at the bottom for the harm reduction website that has a toolkit that goes over how to set up a community distribution site. All right, so that moves us on to pharmacy access. And what I'm talking about is pharmacy access as far as furnishing goes. The first step will be to find a pharmacy that will work with you on this. And I know it's been a challenge for a number of the coalitions. And you'll probably learn, or you've stumbled across some pharmacists that are motivated and interested, and they can be champions within their company to get all the other pieces in place. You also might want to think about pharmacies that are already dispensing naloxone, and this might start with you sending a prescription to them. Pharmacies that are already dispensing it by prescription will be familiar with the product and the process and the counseling requirements, and they're going to be closer to actually furnishing it on their own authority. Pharmacies that are dispensing a lot of opioids may also be a good target, not only because the patients are there, but because they're probably scared and they're going to be inherently more motivated to provide these protections. Those pharmacies that are close to large clinics in your community, also a good place to start. And a number of the chains have started down this path already, if not completed it. They've trained all their pharmacists. They put them through the 1-hour CE. They've established protocols in place. They got stickers on their telephones that say, we can do naloxone. They've really come very far. So you can check and see if any of your local pharmacies are advertising it. They would also be good partners. All right, so once you get to the pharmacy, these are the steps that you can share with them. If they ask, what do I need to do? If you talk to any of the pharmacists there, what do I need to do to get this up and running? First and foremost, have them review the statewide protocol. It spells out everything necessary. They'll have to complete 1 hour of approved CE. This link goes to a free training. They would have to get an NPI, and this is because the pharmacist that's furnishing it, it becomes the prescriber on record. That goes to the insurance company. So in order to get reimbursed for it, they're going to have an MPI. And then for Medi-Cal, because we don't have contracts directly with pharmacists, they would have to be called what's called an ordering, referring, prescribing provider. And this bulletin here explains the process, and they have to submit that information to the state so that they are signed up with us. All right, after they've gone through that process, we have to collect some resources, including the naloxone products. And again, if they've been receiving prescriptions, they probably already have a number of naloxone products on site. But if they're gearing up for this, they may have to purchase some. And most of the products come with trainers or some other device that they can use. There's going to be patient education materials. The Board of Pharmacy actually has them available. And then this is probably the most challenging part because we don't have a lot of input on it, but there's going to have to be some internal procedure for how to handle naloxone requests, because they're going to happen in a few different ways. One of them is someone's going to show up at the pharmacy and say, hey, can I get some naloxone? And the person that is there talking to them might be a clerk or a technician. It may not be the pharmacist. And if they're not aware of the availability and the process, they might turn them away, and that'd be really unfortunate. So there has to be some procedure for what to do when these calls come in asking if they have it, or people present to the pharmacy looking for it. It's going to be important that everyone's aware of the availability. The second piece is having some proactive selection criteria, and it comes back to who we co-prescribe naloxone for. If you look at some easy, low-hanging fruit of high-risk patients, you could have this information in mind and be able to identify those patients and offer it to them instead of having them ask for it. You could be more proactive about it. And that's a very, I think, important set of criteria to establish as well. The other piece is you'll have to have referral sites for both testing and for treatment. And from the coalition standpoint, that's information that the pharmacies may not directly have easy access to. It's something that you could bring to them when you present this request. All right, so we covered co-prescribing, community distribution, and pharmacy access.
James, one quick question, and then we'll need to wind up. The question was, how do you obtain a standing order? Is this just a written prescription that says standing order, or is there a specific form that people should use?
You know, you can make it up your own. There's one on the harm reduction website that you can just take, and I think you can even get it as a Word document. You could change the branding on it from the Department of Public Health to whoever, and you get it signed by a physician. It's really quite simple.
Great, thanks.
You're welcome. So
okay.
just to wrap up, start small and spread it out. Pick one pharmacy or one clinic to start this, and make sure you pursue all the avenues of naloxone distribution. And beyond trying to establish new programs, try to engage people in your community to ask for it. The more of a demand there is, the more of a supply that'll fill it in. Thanks, Kelly.
Thanks so much, James. That was very helpful. And I'm going to turn it over to Dr. Gary Tsai from LA Public Health to talk about how you're doing this in Los Angeles. So take it away, Gary.
Hi, so today I'll be talking about SafeMed LA, which is Los Angeles County's Prescription Drug Abuse Coalition, and our strategy to expanding naloxone through our countywide coalition. Here you can see the outline of today's talk. We'll start off with some data about prescribing in Los Angeles County, an overview of our SafeMed LA coalition, and then talk a little bit about our approach towards expanding naloxone through SafeMed LA. So prescribing in Los Angeles County by the numbers. Here you'll see the prescriptions that were filled in Los Angeles County in 2012. As you can see, about 44% of prescriptions were opioid medications. 40% were sedative medications such as benzodiazepines. Of the opioid medications that were prescribed, about 2/3 were hydrocodone. So Vicodin or hydrocodone is the most popular opioid prescribed in LA County. Also just want to point out the importance of us focusing not just on opioids for prescription drug abuse, but also sedatives. This is a growing class of medications that is also problematic, particularly when used concurrently with opioids, as we know. On the next slide depicts the fact that a relatively small number of prescribers write the majority of opioid prescriptions here in LA, as well as likely elsewhere. 25% of LA County prescribers write about 90% of opioid prescriptions. What this tells us is that if we can target that proportion of prescribers with safe prescribing guidelines, naloxone, co-prescribing, etc., that would be a particularly impactful group of prescribers to target, and that we can get valuable benefit by focusing energies on that population. So moving on to an overview of SafeMed LA. This is our broad cross-sector private partner coalition that's taking a coordinated and multi-pronged approach to address prescription drug abuse in LA County. We have our website listed on this slide. I encourage you to check out the website if you want more details. But the work of SafeMed LA is guided by a 5-year strategic plan that we developed. The goal at the end of those 5 years is to decrease prescription drug abuse deaths in Los Angeles County by 20%. And how we're approaching this is via what we call a 9-6-10 approach. 9 action teams focusing on 6 priority areas and 10 key objectives. And I won't be going all of the priority areas or key objectives today. However, you can see on the bottom of this slide, we link our strategic plan for more details. However, on the next slide, I did want to talk a little bit about our 9 action teams. This is really what guides the work of our coalition. This is the structure. So you can see that we have a steering committee comprised of 1 to 2 members of each action team. We have on the top 2 safe prescribing action teams, one focusing on medical practice and another one focusing on pharmacy practice. And the reason why we wanted to split out safe prescribing into two separate action teams is because we felt that pharmacists were a really important member of the health professional team that sometimes is overlooked in efforts to combat the opioid epidemic. And the reason why they're important is because they're oftentimes the last professional who sees an individual before they obtain their prescription. And so there's a real learning and educational opportunity there. On the top right, you can see that we have a medication-assisted treatment action team focusing on expanding access to MAT, such as buprenorphine, naltrexone, methadone, etc. We have a naloxone action team focusing on expanding access to naloxone. On the left, we have a community education action team. We realize that comprehensively and effectively addressing prescription drug abuse will require messaging to the community, specifically about the risks of prescription drug abuse, and also what can be done about those risks. On the bottom left, you'll also see an action team focusing on cures, which is the prescription drug monitoring program here in California. There was legislation requiring all prescribers to register for cures, but not necessarily utilize it. And so this action team is focused around increasing the actual utilization of cures to ensure that prescribers can identify when people are obtaining their controlled substances from multiple sources, multiple prescribers, and multiple pharmacies. On the bottom right, you'll see that we also have a safe drug disposal action team focused on ensuring that there are easily accessible and environmentally safe ways for the community to dispose of unused and unwanted prescription drugs. This is one component of, I think, comprehensively addressing prescription drug abuse. We also have a law enforcement action team. We realize that this is not simply an issue with the healthcare system, that the opioid epidemic is an issue that also involves our criminal justice partners, and wanted to make sure that they were involved and active in this effort. And then lastly, we have a data collection action team focusing on helping all of the other action teams have access to data so that their respective goals are smart. So they're specific, measurable, accessible, and overall quantifiable. And so as you can see, the work of the coalition is really broad, and that was intentional. We believe in taking what we call a blanket approach, so that we're addressing all the different potential contributing factors of prescription drug abuse simultaneously, in order to avoid the phenomenon of addressing one aspect of the issue only to have another aspect of the issue balloon up and get worse. An example of that is concern about clamping down on safe prescribing, or on inappropriate prescribing rather, with safe prescribing guidelines. To the point where people who are currently dependent on opioid pain medications no longer have access, and then without accessible medication-assisted treatment or substance use treatment, the concern is that they would go to other opioids such as heroin. And that's certainly not something that we want to see happening. And so really we wanted to take this blanket approach in order to address all elements of the prescription drug abuse issue simultaneously. So on the next slide, we'll spend some time talking about Safe MedLA's naloxone strategy. The following slide highlights some of the key points of recognition that we started with when we were thinking about how we wanted to strategically approach expansion of naloxone. The first is just that we all recognized that naloxone was a life-saving tool in the opioid epidemic, that it's similar to how epinephrine is used for anaphylactic shock in order to reverse opioid overdoses within a matter of minutes. We also recognize that research has demonstrated that those at highest risk for opioid overdoses oftentimes are individuals who experience periods of reduced opioid tolerance. So those are individuals who are re-entering the community from jails or prisons, or re-entering the community after leaving substance use treatment facilities, residential treatment facilities in particular, and that targeting those populations would help us yield the greatest value in terms of investment of our time and energies. Also, in talking to first responders and law enforcement groups, it was very clear that the intranasal or needleless version of naloxone was preferable, largely due to safety reasons and because police chiefs and sheriffs didn't want their officers having to deal with needles out in the field, where sometimes they would come across agitated individuals or situations that were unpredictable. We also recognize that the opioid misuse issue is evolving, particularly because synthetic opioids are evolving. And there's been data from around the country that synthetic opioids and high-potency opioids, such as fentanyl and carfentanil, are increasingly being used and increasingly being implicated in drug overdoses. And so as a result of that evolution, the treatment for overdoses will also need to evolve, particularly in the sense of higher doses of naloxone and multiple doses of naloxone likely being necessary in order to adequately address overdoses from high-potency opioids such as carfentanil and fentanyl. And then lastly, what I mentioned previously, we really wanted to make sure that pharmacists were part of the naloxone effort, particularly in California because of recent legislation allowing them to furnish naloxone without a physician's prescription. So on the next slide, it helps to outline where we started from and where we knew we wanted to take our coalition efforts in terms of naloxone. So back in 2006, we formed a Los Angeles overdose prevention task force that was focused on expanding naloxone access to our communities. This was comprised of a small network of naloxone distributors, primarily based out of harm reduction programs, as well as some substance use treatment providers. And where we wanted to take this was based off of the evidence. We knew that there were certain groups of individuals who are at higher risk for opioid overdoses, in particular those in jail. And so we wanted to make sure that we engaged all our law enforcement partners around considering naloxone distribution program in the jail setting. We also knew that there are individuals being treated for opioid use disorders in substance use settings were a high-risk group, and wanted to try to leverage access to naloxone via both the drug Medi-Cal waiver as well as fee-for-service Medi-Cal. Now that as of October 1st, 2016, intranasal naloxone is available via fee-for-service Medi-Cal without a treatment authorization request. And then lastly, we wanted to again activate and engage the pharmacy community to help expand access. Additionally, we thought that it was important to engage first responders, particularly law enforcement, around ensuring naloxone access. We had learned that San Diego County's Sheriff's Department, as well as Orange counties, have implemented naloxone distribution programs. There's some early data out of San Diego saying that almost 40 lives have been saved during the period of their naloxone program, which began in 2014. And so there certainly have been positive experiences there that we wanted to learn from, and we wanted to explore here in Los Angeles. On the next slide, just emphasizes the role of pharmacists in terms of being able to educate their clients, people who come to the pharmacy in order to pick up their medications, around having conversations about safe opioid use as well as pain management, overdose prevention with naloxone, as well as alternatives to opioids, such as physical therapy or anti-inflammatory medications, exercise, etc. So on the next couple of slides, we're going to highlight some of the action teams that are working on our naloxone efforts. The first is the Pharmacy Practice Action Team. In addition to focusing on the role of pharmacists in terms of education and safe prescribing, we really wanted to also make sure that our pharmacy practice action team worked with our naloxone team to focus on the necessary education and training that was needed in order for pharmacists to furnish naloxone in California without a physician's prescription. This new regulation was adopted as of January 2016 and was meant to expand access to naloxone and to not require a physician's prescription in order for someone to obtain this potentially life-saving medication. So we wanted to ensure that pharmacists were actually maximizing their ability to provide this medication. On the next slide, we have outlined our naloxone access action team. The focuses of this action team are really to increase the number of naloxone kits that are distributed throughout the county, to work with the pharmacy team around ensuring the education and training that I mentioned previously, and also to explore expanding naloxone access to criminal justice settings. The next slide talks about our law enforcement action team, which is focusing on safe drug disposal partly because we have 21 sheriff stations where they have safe drug drop-off boxes or bins in front of their sheriff stations. The law enforcement action team is also designed to try to expand and increase information sharing in order to better identify problematic prescribers, as well as pill mills. And then lastly, the law enforcement team is working with the naloxone team as well as the pharmacy team to explore expanding naloxone access to the criminal justice setting. A really important aspect of the coalition work of SafeMed LA is identifying opportunities to synergize interventions across action teams. And so on the next slide, we highlight some of the work that our pharmacy team has done with our naloxone action team, particularly around organizing and coordinating a pain management conference that focused on chronic pain management, medication-assisted treatment, as well as naloxone. Specific to naloxone, we were very excited because we had 200 pharmacists who attended this conference and received the 1-hour required CE training in order for them to furnish naloxone without a physician's prescription here in California. That has been one of the barriers that we've heard from pharmacists about being able to furnish naloxone, is that a lot of them haven't had access to the required 1 hour of training. And so in this forum, through the Pain Management Conference, we were able to provide that. We also, our pharmacy team also engaged in role-playing around initiating discussions with patients, family, providers, about safe opioid use, some of the risks, some of the alternatives, as well as naloxone. On the next slide, we've also identified synergies between law enforcement and naloxone. Particularly, we connected the manufacturer of the preferred intranasal formulation of naloxone with various first responders throughout the county who are now at various stages of considering piloting naloxone programs. Also, a big focus of these synergies was around relationship building between the leads of our SafeMed LA coalition and various criminal justice and first responder groups, such as the fire department, the police department, sheriff's department, Police Chiefs Association, etc. And so really building those relationships so that they could begin to explore opportunities to expand naloxone and also be a part of the solution of the opioid epidemic. Some of the challenges and associated strategies, funding for a long time was mentioned as a challenge and for naloxone. this has been improved now that intranasal naloxone is available via fee-for-service Medi-Cal without a treatment authorization request, and also will be available via drug Medi-Cal in opioid treatment program settings for counties that are implementing the drug Medi-Cal organized delivery system waiver. But for areas where funding continues to be a challenge, there are federal grants, one in particular that was recently awarded to California to address the prescription epidemic that included funding for naloxone and opioid overdose prevention. Those funds are still being vetted at the state level in order to figure out how best to distribute that funding. Additionally, there are opportunities to engage with the manufacturers of naloxone in order to figure out if potentially piloting a program in a particular setting, such as a criminal justice setting or with certain providers, might be something that they would be interested in and lending their support in. Another challenge that we came across was that pharmacists were telling us that their staff and their pharmacists largely were familiar with the regulatory change, whereby pharmacists could furnish naloxone, but didn't have the necessary training or education in order to start furnishing naloxone. And so this is one of the reasons why our action teams worked together to convene a pain management conference where they provided that 1 hour necessary CE training around naloxone. We've also talked about taking different messaging strategies in order to continue to expand training and educational opportunities. So conferences, I highlighted already, but we've talked about expanding strategies to include webinars, as well as potentially engaging health plans around their interest in working with our coalition to expand naloxone access. Additionally, on the next slide, previously I'd mentioned role playing. Pharmacists had also expressed a need for additional training around how to have conversations with patients, families, and also providers around opioid risks, safe prescribing guidelines, and naloxone. And so because of this, we made role-playing a agenda item within that pain management conference that our pharmacy team and naloxone action team helped to organize, so that we could really help the attendees and pharmacists in particular start to learn how to approach providers, patients, and families around these issues. We've also talked about the importance of engaging health professionals in training, in this case pharmacy students, around these practices so that they're integrated into their practices at an early point in their training. We think this is really important. And then lastly, engaging law enforcement sometimes has been challenging just due to their need to balance various priorities, concerns about patrol officers using naloxone, in particular the injectable version, and also concerns about funding and how to access naloxone in a way that's economically feasible. Strategies around this have largely focused on relationship building and really conveying why we think the criminal justice community and our law enforcement partners are an important component of the solution to the opioid epidemic, and also providing them tools, in particular this law enforcement naloxone toolkit that's available on the referenced website on this slide, that can provide them information to their superiors and also to their officers about why naloxone is something that officers can and should carry and what some of the potential benefits are, both to the law enforcement community and also to the general public. Part of that relationship building I referenced previously was also connecting them with the manufacturers of intranasal naloxone in order to explore opportunities to make this formulation more accessible. In my last couple of slides, two key takeaways from our SafeMed LA naloxone efforts so far have been that, number one, culture change is absolutely necessary in order to achieve the change that we're looking for and get naloxone in the hands of people who need it. It's really important for us to not just to change prescribing practice amongst health professionals, but also to change the public's perception about how they view pain, how they view medications, and what they view as acceptable pain. Changing those perceptions will, in large way, change the demand for these medications, which then will also change the supply. We also, another takeaway has been that we need to ensure that we're collaborating and communicating between all of the different health professionals that are a part of this issue, as well as patients and family, particularly around naloxone and why it's important to get naloxone in the hands of individuals who are using opioids, particularly at higher dosages, and also individuals who are at higher risk, such as those who are leaving residential substance use settings as well as jail and prison settings. The second takeaway that we learned from our SafeMed LA naloxone efforts has been that identifying opportunities to better collaborate and synergize across action teams and stakeholders is really critical. We, particularly around the issue of naloxone, we came across a lot of different opportunities for our pharmacy action team, naloxone action team, as well as law enforcement action team, all work together to achieve their shared goals of expanding access to naloxone. Whether it's in the pharmacy setting with pharmacists who can now furnish naloxone without a physician's prescription, or in the criminal justice setting to make sure that officers responding to the scene of individuals who have overdosed have access to this life-saving medication. So with that, my contact information is here on this last slide, along with the website for SafeMed LA. And just want to thank you for your time, and feel free to email me if there are any questions. Thank you.
Well, Dr. Sai, thank you so much. And all of these slides and the recording will be on our website. And it's so encouraging to see the work that LA is doing, because we're definitely seeing, when coalitions come together, some early signs that death rates are dropping, huge numbers of reversed overdose deaths that would have had tragic outcomes otherwise. So our final presenter, Dr. Phil Coffin, I wanted to bring him to share a real groundbreaking study of what happens when you co-prescribe naloxone to people getting opioids for chronic pain. So I'm going to turn it over to Dr. Coffin.
All right, so since my slides are going to be up, I will try to jump to the data as quickly as possible. Briefly, my disclosures: I run clinical trials. I've received donated study drugs from Gilead and Alkermes, neither of which have to do with the topic today.
So Philip, we're only seeing half of your slides. I don't know if you've changed the settings.
I have not changed the settings.
Okay, why don't you use that view right now? Just use this view and we'll be fine.
All right. So, so there's some good data from Massachusetts, an interrupted time series analysis that shows that regions that received that dispensed naloxone had lower opioid overdose mortality relative to regions that did not, and this seemed to be somewhat dose dependent, in that the more naloxone that get out, the lower the rates of opioid overdose. And there are similar data from California that are in press right now. In addition, naloxone has been shown to be cost-effective when given to heroin users. So getting naloxone to people who use drugs is really the biggest bang for your buck in terms of getting it to where overdoses happen and where they can be reversed. I think it's very important to get naloxone to, let's say, the parents who have a child who has an opioid use disorder, but that child mostly is going to be not, so let's say, using heroin with his or her mother, but is going to be using heroin with friends. So making sure it's in the hands of other people who use drugs is the most important for reducing overdose mortality. I'm going to jump into the study we did here. So we did a implementation science study of naloxone co-prescribing to safety net patients on opioid medications in San Francisco. And the sample of patients we were looking at was just under 2,000 patients, and it was prescribed to about 40% of those patients. We recommended that prescribers offer naloxone to anyone who is on daily opioids, daily or more opioids. So that if they were receiving 30 or more pills a month of any opioid, we recommended offering naloxone to them. Now, prescribers did not necessarily do that, and prescribers varied a lot in how much they offered naloxone. But overall, in terms of the people prescribed naloxone, younger people were somewhat more likely to be prescribed naloxone. Those who are on a higher dose of opioids were more likely to be prescribed naloxone, and those who had had an opioid-related emergency department visit in the 12 months prior to the program were much more likely to be prescribed naloxone. So providers kind of self-selected the people who they felt like were more in need of having naloxone at home. Our analysis of opioid-related emergency department visits showed that that naloxone was strongly associated with a reduction, naloxone being the blue line, in opioid-related emergency department visits among people who got it. We were not powered to test for mortality. We also did interviews with 60 randomly selected patients, 10 from each of the 6 clinics we were working with, to inquire as to, what it was like getting offered naloxone and having naloxone, what did they do with it, and everything, lots of questions about that. And overall, about a third of the patients reported that they had, since they got naloxone, they had been more cautious about dosing, reduced their polysubstance use, not used opiates alone, and things like that, reported these positive behavior changes. Nobody reported any behavior change that could be construed as negative, such as increasing use or things that may be more risky. Then one of the patients said, I've probably been a little more cautious, just being careful to take the right amount, count the hours, think more cautiously about dosing. And these publications are available. There are citations on the slides. Of these patients, there were about 10% had previously received take-home naloxone. We have a robust naloxone distribution program in San Francisco, but this was exciting because that means that 90% of the patients, that at least of those we interviewed, had never received naloxone from anywhere before. So we were reaching a population that was high risk, that did not have other access to naloxone, and almost 40% had a history of overdose. About half of those people who had a history of overdose denied ever overdosing. They said they had a bad reaction to their opioids. And when we asked them about the bad reaction, they described an opioid overdose. They all had a very low perceived risk of actually ever having an overdose. So I've moved on to the next slide. Can everyone, which is a quotation from an interview with one of these patients. This individual had never used illicit substances. It took his opioid medications as prescribed. The interviewer asked, how many times had you said that you've had these bouts of delirium or stopped breathing because of opioids? Ever? 8 to 10 times. How many times has naloxone been used on you? Oh boy, that would be hard to answer. Somewhere in the neighborhood of 12 to 15 times. So around 12 to 15 times, someone has given you naloxone because you stopped breathing because of opioids. Over what period of time? Over 1 year. So this is just to really demonstrate that the terminology overdose does not work in patient populations. It is really problematic. The proper term would probably be opioid-induced respiratory suppression, but that just doesn't roll off the tongue. The CDC actually has guidelines in terms of who you should prescribe naloxone to at this point.
So Phil, I apologize. We're not seeing the slide again. I don't know if you can go back and forth the way you did before. Here we go.
It says clinicians should incorporate into the management plan strategies to mitigate risk, including offering naloxone when there are factors that increase risk of opioid overdose. And the factors they selected are any history of overdose or of a substance use disorder, being on 50 or more milliequivalents of morphine a day, or current benzodiazepine use. And I think those are pretty good standards. That's going to capture probably most of the high-risk people. One of the important things to think about, though, is if you're trying to decide who you should offer naloxone to in a primary care setting, I would advise against trying to risk stratify patients before offering naloxone, because that brings up this idea that, you know, if they stratify into being high risk, then you shouldn't be then some doctors may think they shouldn't be prescribing opiates to someone who's high risk, but this may be somebody who really, you can't not prescribe opiates to them, and they've been on opiates for a long time and doing incredibly well. And so in that situation, the provider may feel a sort of medical legal conflict and think, okay, so I'm not going to prescribe naloxone because they must not be at risk because I have to prescribe them opiates. And that circle, I think, can really cause problems for some providers. So I recommend not risk stratifying them based on their risk with opioids, but really thinking of it as a risky medication, much like when we prescribe glucagon to someone newly starting on insulin. Doesn't mean we don't prescribe the insulin, even though they may be a high-risk patient who may have hypoglycemia. We still prescribe the insulin because we need to, but we prescribe glucagon as a safety measure. So I think about prescribing naloxone as prescribing it in the setting of risky drugs, not necessarily to a risky patient. So a patient who is prescribed opiates and benzodiazepines and is incredibly safe, but they're on 2 drugs and things can go wrong. They may change the dose of one and not the other, et cetera. So it's good to have the medication in the house, and it's also good to have the medication in the house because sometimes somebody else can accidentally or intentionally access those medications. And there have certainly been examples where children have accessed opioids in the house. The parent has administered naloxone while waiting for paramedics to come, and the child has been awake and alert by the time the paramedics arrive. And that's a very important outcome. So if this is showing up, co-prescribing naloxone, opioids, it's feasible, seems to have some ancillary benefits like reducing opioid-related emergency department visits, which may be through the mechanism of behavior change, of people actually changing how they interact with and how they use and how they think about their opioids. And the term overdose, I really want to just encourage everyone to really stay away from that term when talking with patients. I recommend discussing the opioid safety and medication safety and referring to naloxone as an antidote, much like you would glucagon or epinephrine, and thinking about risky drugs, not risky patients, trying to make sure naloxone is where the risky medications are. I'll stop there so we have a couple minutes for questions.
Thank you so much, Dr. Cochran. I really appreciate that, and I apologize to all that we had these technical difficulties. I'm not sure what happened, but we'll look into it. We had a lot of chat questions about standing orders and how you get information about training, and we shared links on the chat function, and when we send out your email within the next week, we'll make sure you have access to all of these links so you can get more information about standing orders, about train the trainer programs, and we'll also make sure you have access to slides and a copy of this recording. I also wanted to call out a question that came up about first responders, and wanted to invite maybe James Gasper, if you could say anything about where people can get training for first responders, or how first responders, like police officers, can learn more about carrying naloxone.
Yeah, for first responders, it's usually run through and administered by the local EMS department. So the medical director of the EMS is often the person that's used to sign off on the standing order and is therefore responsible for the drug that's being handed out by law enforcement officers. And the training curriculum is already in place, and many of the resources that we've already shared through the Harm Reduction Coalition involve, a lot of the same degree of detail for officers that, is applicable as it is for bystander administration.
Great, thank you. And so, Robert, if you could put the last slide up, I just want to highlight we have another webinar coming up on December 13th. And this is focused on coalitions who want to work on evolving your goals. Many of you launched a year ago and set SMART goals at that time. So how do you look at those goals and adjust for the inevitable environmental factors that make us have to pivot or change course? So we have seen the most effective coalitions are those who set very specific measurable goals, continue to measure their progress, and continue to move along. An example is if you say, well, you're going to train some doctors, you'll end up training far fewer than if you say you're going to train 15% of the doctors in your community by year 1 and 50% by year 2. I also want to call out that we've got our fall convening. We had over 450 people at our convening at September 22nd in Oakland. It was very well received. It's just a great way to get inspired about this work. And we're repeating the same agenda featuring local coalition leaders on November 1st in Newport Beach. So please do register for that coalition convening. You don't have to be part of a formal coalition. It's open to the public and it is free. So we would love to see you there. Again, all of this information will be sent to you by email, and the recording will be available to you as well as the slides. And so thank you so much, and have a great day.